I would like to thank the department for the opportunity to talk this morning. I started last year's grand rounds with this slide. And I felt like I really left the audience down because I didn't give any data. I just gave jokes about how a lot of our attendings had mustaches in the past. So I wanted to update you on the data in the field of orthopedics about facial hair. Bearded healthcare workers have lower rates of staph and MRSA than your non-bearded colleagues. These are all real studies, by the way. Bearded surgeons did not appear to have an increased likelihood of bacterial shedding compared to their non-bearded counterparts while wearing surgical masks, and the addition of non-sterile surgical hoods did not decrease the amount of bacterial shedding. And if you don't believe in modern research, which maybe you won't after my talk, take this editorial from the Boston Medical and Surgical Journal from 1843, which is now the New England Journal of Medicine, that the practice of shaving the beard and thus depriving the face, throat, and chest of the efficient protection which nature has provided is one of those pernicious customs which an imperious and blind fashion has introduced, and which has conduced materially to the production of the numerous diseases of respiratory organs of which mankind are afflicted. And so I think it's safe to say that beards are safe in the surgical suites. But moving on to today's topic, I'll be discussing with you largely about the fragility of orthopedic trials and whether you should care about that. I'd like to thank Dr. Marchand for his guidance and help in creating this talk, and Dr. Dave Granger for some last-minute pointers. We'll first discuss the origins of the p-value, and then we'll discuss fragility in orthopedic studies. Following that, we'll examine some examples and studies to show how that affects the outcomes. And then finally, we'll finish by talking about where we can go from here. So, where did the p-value come from? Dr. Ronald Fisher was born in London in the late 1800s and is considered one of the most influential statisticians in the history of the field. While a professor, he wrote numerous books, including The Design of Experiments. In it, he describes a story in which a lady was irate at a server for pouring tea over her milk instead of milk over her tea. She claimed she could tell the difference between the two methods, which Fisher thought was ludicrous. So he designed an experiment to tell chance from the truth. And through this experiment in his book, as well as his other book, Statistical Methods for Research Workers, he popularized null hypothesis significant testing and the p-value. So what better way to show his experiment than to reenact it right here in front of you today? So Dr. Spiker is a tea connoisseur, and over the past 5 years has ragged on me for not removing my tea bag after 5 minutes in the fishbowl. And he claims that he can tell the difference between a tea steeped for 5 minutes versus a tea steeped for 10 minutes. So I've invited him here today. For those of you that aren't on Zoom, he is sitting in front of us today, and he's going to come down and he's going to perform the exact experiment that Dr. Fisher wrote about in 1935. And here are the rules. There are 4 cups of tea that have been steeped for 5 minutes and 4 that have been steeped for 10 minutes. Dr. Spiker can taste all 8 cups and return to taste them again. But at the end of the experiment, he needs to identify the 4 cups that he thinks were steeped for 5 minutes. And the null hypothesis for this test is that Dr. Spiker, in fact, cannot tell the difference between the 2 teas. So he's going to start testing these teas right now. He's sitting in the front row, tasting these teas. And as he does this, I'm going to explain to you how we got to the p-value. So in this experiment, there are 70 unique outcomes. There is only one way to get all of them wrong and all of them right. There are 4 ways to get 1 right and 1 wrong, or 1 right or 3 right. And then there are 6 ways to get 2 right and 2 wrong. And since there are 2 sets of 4 cups, you multiply those outcomes by each other, and you get 8 choose 4 in combination mathematics, or 70 unique outcomes for this study. The p-value was then determined as the probability or the chance that another outcome is equal to or more extreme than the one that you found in your experiment, assuming the null hypothesis is in fact correct. In other words, what percentage of all of the outcomes are equal to or better than the one that you found? And then he chose p equals 0.05 as the limit for statistical significance, meaning rejecting the null hypothesis. This quote explains why. The value for which p equals 0.05, or 1 in 20, is 1.96 or nearly 2. it is convenient to take this point as a limit in judging whether a deviation is to be considered significant or not. When he refers to 1.96, he's referring to the standard normal distribution, in which 1.96 standard deviations from the mean is the 97.5th percentile. As such, plus or minus 1.96 standard deviations gives 95% of the normal distributions. And since then, P equals 0.05 has been the most important statement in medical trials. However, Fisher also said that one should only reject the hypothesis if properly designed trials rarely fail to give significant results, meaning 1 or 2 trials is not sufficient to reject the null hypothesis even with significant p-values. So Dr. Spiker is finishing up, and I'm going to go judge how he did. He has selected. You think these are 5s or 10s?
Not very confident.
10. Okay. So, Dr. Spiker selected 2 right and 2 wrong. So, to calculate his p-value in a Fisher's exact test, you have 36 outcomes from your 2 right category plus 16 outcomes from your 3 right plus 1 from them all right over 70. So his p-value equals, I thought he was going to get 3 right, so I had planned for that one. So 53 is 0.75. So statistically insignificant chance that Dr. Spiker can tell the difference between 5 and 10 minutes. But that doesn't mean that the null hypothesis is right or wrong. It just means that in this small sample size, that Dr. Spiker did not correctly guess the correct one. So I'd like to thank Dr. Spiker for coming. I appreciate you doing that for us. Now that we understand what the p-value in Fisher's exact test is, let's move on to fragility. Fragility of a clinical trial was first described as a concept in 1990 by Dr. Feinstein in this article from the Journal of Clinical Epidemiology. He discussed the concept of the unit fragility index as the difference in outcomes if there was a change in 1 unit either way to the original study table, as seen here on the right. What was discovered was that the unit fragility index was a function of the sample size of each cohort, or the total sample size divided by the product of each cohort. Feinstein then went on to describe that the investigators needed to determine a minimal clinical significant difference in MCID and the difference in their study. And that if the difference in their study less the fragility index was still greater than the MCID, then this study was statistically stable as well as clinically relevant. This work was further characterized by Walter in the same journal in 1991. And while the image to the right is a crude estimate on PubMed of articles mentioning fragility index, which I unfortunately learned the hard way, includes a lot of glass and material science research, the recent uptick in the interest in this concept started less than 10 years ago, more than 20 years from the original article. In 2014, Walsh et al. Published the current idea of the fragility index. He described that the concept of determining how many occurrences would need to be changed in order to change a p-value from under 0.05 to over 0.05, as can be seen here in the tables by the letter F. 2 key things to note here is that he always used a Fisher's exact test, as well as the data must be dichotomous in a 2-by-2 manner. In a letter to the editor in 2016, Dr. Ahmed suggested that the fragility index did not take into account trial size, and that should be normalized to be compared across trials. As such, he suggested the fragility quotient, dividing the index by the total sample size. This number can be thought of as the percent of total sample size that needed to experience an opposite result in order to switch the statistical significance. And without a doubt, this concept then caught on in orthopedic literature. And what is easier than a systematic review of randomized controlled trials in a subspecialty of orthopedics with easy to accomplish statistics? Probably only falling asleep standing up as an orthopedic surgeon. But in all honesty, this was low-hanging fruit for the orthopedic research world. And as of last year, there have been a systematic review in each subspecialty of orthopedics looking at the fragility of randomized controlled trials in that field. And I will briefly review them all in order of publication year. 2 reviews have been published in the spine literature on the topic, both with similar results, likely because they included very similar studies, which was that the median fragility index of these studies was 2. Meaning only 2 patients needed to switch outcomes in order to make the study's p-value go from significant to insignificant. The median loss to follow-up was 5 in one study and 1 in another. And for randomized controlled trials, there were more patients lost to follow-up than needed to switch the outcomes in the study. Studies were pulled from any journal and rated on a Cochrane collaboration risk of bias tool. Similar to the spine studies, Kahn et al. Looked at 10 years of RCTs surrounding sports topics. 48 RCTs were included in the analysis and showed a median fragility index of 2. While in the second study, 102 total studies, including RCTs and comparative studies from JBJS and AJSM, found a fragility index of 5, but a mean loss to follow-up of 8. In the same vein as the previous study, this review of 17 pediatric RCTs showed a median sample size of 116, but a median fragility index of only 3. In the hand literature, there were only 5 RCTs from the high-impact journals of orthopedics, as well as New England Journal of Medicine, JAMA, Lancet, and BMJ, and they were included in this review. They found that the median fragility index was 3, and meaning that only 3 patients, again, needed to switch outcomes to increase a p-value to 0.05 for these studies. They had a median loss to follow-up of 2. This trend continues with no great surprise. From trauma, 198 comparative studies, including retrospective and prospective studies from JBJS and JOT, were included in this review. When they looked at only RCTs, they found a median fragility index of 4, with a median index of all studies of 5. No loss to follow-up was presented in this study. Again, in the shoulder and elbow literature, the fragility index of RCTs was found to be 4. However, this excluded all studies with a fragility index of 0, which if you included them would drop the fragility index to 1.5 with a mean loss to follow-up of 5.6. The same study in arthroplasty of 34 RCTs had a median fragility index of 1, with 35% of studies having a loss of follow-up greater than the fragility index. Even sarcoma has a review, and very similar numbers were found of a fragility index of 4, of over 23 studies and average a loss of follow-up of 9. And in 2018, this group from Oklahoma State looked at all of the strongly recommended clinical practice guidelines from the Academy and evaluated the RCTs that made up those recommendations. They evaluated for bias, fragility, and power. And they found that the median fragility index of these studies was 2. The median fragility quotient was 0.02. And 32% of studies had a loss of follow-up greater than the fragility index. Even more concerning, they found that over half, or 53%, of these studies were underpowered. So if you crudely perform a systematic review of all the RCTs I just presented in all of those studies and amass a median fragility index of all RCTs in orthopedics, it would be 2. But what does that look like on a trial level? This trial, published in the Journal of Shoulder and Elbow Surgery in 2013, prospectively randomized 90 patients to either single or double row repair and an isolated supraspinatus tear. They were looking at 1-year healing rates as determined by ultrasound. At 1 year, they had 83 patients follow up and found 75%, or 30 of 40 patients in the single row, and 93%, or 40 of 43 patients in a double row, had healed. They used a chi-squared analysis, which could be considered controversial, but found a p-value of 0.01 and concluded that double row repair was superior to single row in an isolated supraspinatus tear. But what if we said there was a 5 to 10% diagnostic error in ultrasound evaluation? Even dropping that to 3%, which is a reasonable number, that would change the 2x2 table to 2 patients in the single row group and 1 patient in the double row, and make the 2x2 table look like this. And if you run a Fisher's exact test, the p-value is 0.21. And so then you have a completely different conclusion from your study. But we had the world's best ultrasonographer for this study, and there was no error in diagnosis. But we did have 7 patients that failed to follow up. And since the groups of the patients that did not follow up were not reported, for simplicity, we will make all the groups equal to 45. So that means that in the five people were added to the single row and 2 were added to the double row. If you say, for example, 4 were healed in the single row and 1 was healed in the double row, this changes the 2x2 table to this, barely changing your percent healed values on the bottom right of the table. But if you run the Fisher's exact test of this study, your p-value is 0.08. And the fragility index for this study turned out to be 1 with a fragility quotient of 0.012. How about this landmark study from Dr. Bone that changed the care of patients with femoral shaft fractures? 178 patients were randomized to early care versus late care. In the subgroup of multi-traumatized patients, there was a significant difference in the rate of intubation for patients treated early versus late. But if you change just 4 outcomes in this study, the result becomes insignificant. And the fragility quotient is under 5% of the total number of patients in the study, which is the same percent that we use for a significant p-value. And a reasonable criticism of the previous studies might be that they are small numbers. One might think that large trials are immune from this phenomenon. This trial from 1992 was published in The Lancet and had over 1,000 patients in each treatment arm. They looked at 1 day of continuous infusion of magnesium on binary 28-day mortality. They had 2,300 patients follow up for final analysis, meaning they had 16 patients that were lost to follow-up. They found that a mortality rate of 7.8% in the magnesium group and 10.3% in the placebo group for a p-value of 0.04. That is a 2.5% absolute mortality reduction and a 25% relative risk reduction. However, if you change just 1 outcome in the magnesium group, that changes the mortality reduction from 2.5 to 2.4% and barely changes the percent mortality in both groups. But the p-value changes from 0.04 to 0.06, changing the conclusion of the study. But should it? Subsequent studies over the past years had 58,000 patients along with systematic reviews on the topic showed that magnesium, in fact, does not have an effect on mortality. But I would argue that this example highlights what's good about the p-value and what Dr. Fisher wanted it to be used for. One group found an association and others repeated the study and did not find ultimately any association in the use of magnesium. So what does this all mean? The first thing to understand about fragility index is the flaws. It is not a perfect measurement and is criticized by many. The critics of the index say that the fragility index is just another p-value and does not add anything to avoid the arbitrariness of 0.05. And as you can see on the graph on the right, that the fragility index is loosely associated with the p-value. Secondly, the fragility index is described as using a Fisher's exact test. This is how you can get a fragility index of 0. When studies use a different test, like chi-squared, and numbers are put into a Fisher's exact test, the p-value may return greater than 0.05, giving it a fragility index of 0. In the same light, time-to-event statistical tests are newer and more sensitive to changes, and fragility indices should not be used for these types of studies. Again, the Fisher's test is only for categorical data. So continuous variables are not able to be given a fragility index, but statisticians are working on a test for this type of variable. And lastly, these were the results of the trial. 1 or 2 or 3 patients did not have a different outcome. So at some point, we must take the trials for what they reported. A concept that I'd not given much thought of until recently in researching this was, what if you have 2 studies on the same topic and they have the same p-value? What does that mean for their findings? Does it mean the same? Take this example from Gail Potter of a coin and determining whether a coin is fair. These are 2 different coins and have in 2 different experiments, but have a p-value of 0.002, displaying there's a statistically significant findings that the coin is in fact not fair. But which study is more convincing? Using Bayesian statistics, which is a theory of statistics that uses what we know and adds to it what we learned from the study, you know that the coin had a 50% heads probability to start. And then using Bayes factors that is developed from the p-value and sample size to determine the new percent of head probability, you can determine which study is more impressive. What you should take from this chart is that the Bayes factor is developed from p-values and sample size, in that the Bayes factor is bigger for decreasing sample size and p-values. In other words, in order to get a small trial to have the same p-value as a large trial, the effect difference must be larger, and therefore is more convincing statistically that of the effect it is measuring. That does not mean we should be aiming for small trials. It just means to keep in mind when you're looking at small trials with significant p-values, that means there is a more impressive difference between the two groups. The issues with p-value is not a new concept. In 1986, Drs. Gardner and Altman published this review advocating for the use of 95% confidence intervals. And when it comes to evaluating studies, everything should be taken into account. A p-value of less than 0.05 should raise interest, but not be taken as fact. If there are large confidence intervals, that should raise questions, but not eliminate the possibility of a true finding. Alternatively, small studies with statistically significant findings should not be disregarded. Another Dr. Altman, unrelated from my Wikipedia stalking, published this fascinating editorial in Nature over 4 years ago. She explained the nuts and bolts behind running statistical tests on large sets of data points. She described that one must be careful in how we interpret p-values using data sets for research. She cautions that we must make it clear whether we are confirming inferences or generating hypotheses, and that statistics must be adjusted for multiple testing. She also provided an equation for the probability of finding a p-value of less than 0.05 based on the number of independent tests you run on that data set. So if you run 14 independent variables from a data set, you have an over 50% chance of finding a significant p-value of less than 0.05, regardless if there's associations. This is hammered home by the article written by Dr. David Lineweber, where he was able to model the ending value of the S&P 500 to almost a perfect degree and statistically significant by the butter and sheep production in the United States and Bangladesh and the cheese production in the United States. In the next logical step, Nature published editorials regarding the use of p-values in their studies, whereas others have suggested that lowering the p-value threshold would be better. The idea is that studies, again, should be evaluated on their findings and the strengths of those findings, not by certain p-values, and that all statistical interventions and the merit of their study design and sample size should be taken into account. While this is certainly an interesting and well thought out process, changing the last 100 years of scientific research will be a mountain to climb, but the journal Nature is as good as it gets and a good place to start. Of note, Nature is still publishing p-values in their paper and have not made a full switch yet. Even the American Statistical Association felt it important enough to make a statement on the p-value. This is what the executive director had to say. The p-value was never intended to be a substitute for scientific reasoning. Well-reasoned statistical arguments contain much more than the value of a single number and whether that number exceeds an arbitrary threshold. The ASA statement is intended to steer research into a, quote, post p less than 0.05 error. And while they admit this is not a new issue in this statement, they mentioned that this is the first time statisticians have made a comment on it in the form of their association. The Fragility Index is just another statistical check to a study to help the reader evaluate the findings. The number should be taken into account, and no arbitrary number should be given to it to assign whether a study is stable or unstable. And there are significant flaws to the index, and these should be remembered when evaluating it. But I believe that the most important role of a fragility index is to evaluate the loss of follow-up to a study. Even studies with less than 10% loss of follow-up that are considered high quality can have their results changed if patients had actually followed up. There are online calculators for fragility indices that you can use for your own papers or calculate fragility indexes for papers that you read that do not have the values that you would like to know. So while I'm by no means even a novice in understanding the complexity of Bayesian statistics and modeling methods, the idea of using what we already know and adding to it from the results of a study seem to make sense and are intriguing, and I think should be used more often. The p-value is an oft misunderstood and misinterpreted statistic. It does not represent the strength of a finding in a paper or the truth of the difference found in the paper. Often we think of ideas for studies and do literature reviews and find a study on this topic and say, well, that's already been done. A p-value of less than 0.05 should only encourage you to do more research on a topic rather than move on to another question. Even large studies have been shown in subsequent larger studies to be incorrect. So the acceptance of repeating studies, instead of this being looked down upon, should be accepted. The p-value is just merely one piece of the puzzle. I think it has its role, but the p-value of 0.07 should be judged against a p-value of 0.03 in the setting of the whole study. That should not be considered a failure or not worthy of being published. and we should move on from an arbitrary value of 0.05 and evaluate studies for their merit and methodology. I was hoping to be like Dr. Fisher here at the end of researching this topic, wisely puffing a pipe, having understood the role of statistics in scientific studies. But instead, I feel more like Jon Snow from Game of Thrones with more questions than answers. And so I thank you for your attention, and I welcome any questions.
Hey, Pat, what is the probability that you had a selection bias in the sampling of literature you used to support beards?
None, 0. That's about as strong as the literature gets. The sample size was 10, and the p-value was less than 0.05, which means the difference is astronomical. So that the 95% confidence interval has to exist that there is better evidence that beards should be worn by men.
Thank you.
Thanks, Pat.
Patrick,
Important topic.
Pat, I have one question for you.
Yeah.
You kind of alluded to the era of big data is here. Where do you see things going, with the future and how we use big data and study design, et cetera? Have you thought about that much?
Yeah, I think that big data definitely has its role, and I think that it's kind of a double-edged sword. You say that Limit 2 trial was too small and that 58,000 patients is big data and did not find a difference. Graham just did a big data study on distal femoral replacements versus fixing distal femurs, and found that distal femoral replacements had a lower mortality rate, but then he did a propensity analysis of it and matched patients between the two groups with Dr. Martin, and found that whole mortality benefit dropped out. So I think what we need to be aware of when you're doing big data research is that we need to use more complex and likely more Bayesian type of statistical methods and modeling when we're doing big data, and that these simple just finding students' t-tests or Fisher's exact test between big data is not powerful enough and will likely lead to incorrect conclusions.
Great. And I'm just curious too, if any of the research faculty on this call have any thoughts or comments. I think this is a very interesting topic, and how we know what we know. What we don't know what we know is a matter of debate, as you just highlighted. I don't know, Brooke or Amy or anybody else here, do you have a thought on this?
Yeah, this is Amy. Well done. This was a great topic, and I'm glad. I tend to really like using confidence intervals. I think it allows you to see the spread, and that idea that if it's crossing one, gives you a better indicator of where your value sits relative to other studies. So I was glad you mentioned that. So again, really enjoyable talk. Thanks.
Thank you.
Hey, Pat, awesome talk. I just had one question now that you've spent a lot of time thinking about this, which is we sort of, only get one crack sometimes at answering these questions that we deem really important, meaning we can only get the NIH or DOD to give us a couple $1 million one time to run a randomized trial. How do we avoid coming to a really fragile conclusion with a big trial? What do you think the solution to that problem is now that you've been thinking about this a bunch?
Yeah, I think that's a great question. Graham had asked me, there's no way to determine a fragility index before you do a study, right? So that's something you can only figure out after you're done. And so I think that when you're designing these big multi-million-dollar, multi-centered randomized trials, I think you just have to be very aware of your inclusion and exclusion criteria, as well as your methodology of your study. And I think at some point, this is kind of a cop-out answer. When I was interviewing at UC Davis for fellowship, Dr. Lee asked me, can we even answer questions with clinical research? And I think that as of now, of the research that we can do and what we can control, I think you can just have a well done methodologically sound study. And at some point, this is just clinical research. And until we can have a better way of understanding the heterogeneity in humans, it's tough. So it's a little bit of a cop-out answer, Dr. Marchand, but I think that you just have to be very aware of the study that you're making. And
why are we merging all the way up here?
whoa. And be very aware of your methodology.
This is the problem. The
Kristen,
zipper is up there.
Kristen, you're on loud.
Brooke, do you have a comment?
Yeah, can you hear me okay?
Barely.
Just barely.
Let me switch mics here real quick.
Thanks. Really interesting talk. You commented on the size of the sample and the loss to follow-up influences and fragility. I'm just wondering what your thoughts are about choosing what are oftentimes relatively rare outcomes and how that can influence the fragility.
Yeah, I think that when you look at some of these studies, then especially in orthopedics of the trials we do, we're almost using Fisher's exact test because the groups are 1 or 2, the outcomes are kind of 1 in one group and 6 in another. And so I think that using fragility quotients are more telling of a study than fragility indices. The absoluteness of a number of 1 or 2 or 3 doesn't give it true justice. And so I think the rareness of our outcomes in the studies that we need to do certainly plays into our low fragility indices, but we should move towards a fragility quotient. It's a little bit of a weird number to think about, but once you kind of wrap your head around it, I think it's a much more powerful number than just the index itself.
Appreciate it. Thanks.
Okay, thanks, Patrick. I think we're just a couple minutes over time. That's perfect. Thank you very much. Take care.